audio. Yes. This thing is making me feel old. I don't know how to mute.
Good evening, everyone. Hi, my name is Dr. Mreshima Shangu, and welcome to tonight's webinar. Once again, I'd just like to convey my apologies for the postponement that we had last week. However, we are back into the full swing of things with a new topic for us this evening. So for this evening, I would like to introduce one of Clinics' own specialists that we have. Tonight's topic will be delivered by Dr. Lindelani Nevondo. And the topic for tonight is pediatric ankle fracture management. Dr. Lindelani is an orthopedic surgeon currently practicing at Clinics Health Group's Tepo Temba Private Hospital and Vochilong Impolweni Private Hospital. He is also a member of the South African Orthopedic Association. He obtained his MBCHB in 2008 from the University of Pretoria. He then completed a fellowship of the College of Orthopedic Surgeons of South Africa and the College of Medicine of South Africa in 2018. He further completed his Masters of Medicine in Orthopedics from SMU in 2019. So I'd like to welcome to the floor tonight, Dr. Nevondo. Thank you very much, Doc. Over to you.
Unmute. I don't see. Okay, sure. It. Is my slide sharing?
Yes, your slides are sharing, Doc. You just don't have them in presentation mode.
Okay, I can fix that. Like that.
Fantastic.
All right, ready to go. Hey, good evening again to everybody. And thank you, Dr. Mo, for the introduction. And, thank you to everybody who has joined to listen to me again. And thank you to Clinics for giving us the platform. And thank you to my colleagues for this opportunity. And Dr. Moore, I work in Botsilong and September and Lesedi and Naledi Nkanyezi. So I'm like the clinics person. So the topic of today, we're going to talk about pediatric ankle fracture. And the reason for this topic is for the last 3 or maybe 4 or 5 weeks, I've seen a lot of cases which involved children with ankle fractures. Some were almost, if not treated as non-fractures or as something that could be swept under a carpet or some, and some were taken serious. And I just thought this is a topic that we really need to talk about, because when you miss it, it causes quite a lot of problems. Hence the topic today. So what is pediatric ankle fracture? It's actually fractures that happen in skeletal immature people. So it's children. In boys, it will be below the age of in boys, it will be below the age of 16. In girls, it will be below the age of 15, because girls mature faster or earlier than boys. It's the fracture that involves the distal tibia and also the distal fibula. And it involves the metaphysis, the physis, and the epiphysis. So it's not just on the growth plate alone, but it mostly goes through the growth plate. So growth plate, what really is a growth plate? So when you are still growing, growing happens in two formats. You grow in height and you also grow in width. For growth in width or girth, it's through your periosteum. But for you to grow longer in height, that happens through the growth plates. That happens through the growth plates. There's a lot of growth plates that are in the human body. There's a lot of growth plates that are in the human body. You got the distal femur growth plate, you got the proximal tibia, proximal fibula. But the ones we are interested in today, is the growth plate in the distal femur, in the distal tibia, and the distal fibula. So a growth plate, when you zoom into it, it contains 5 zones. And those zones contain different types of cells, or they contain cells in different stages of maturation. There's the resting zone where you have chondrocytes that are metabolically active, but they are not undergoing mitosis, meiosis. And then when they start growing, then they are in the proliferative phase. And then they get in the hypertrophic zone or hypertrophic phase, where now they are growing very big in size. And that is in blue because that is the dangerous, or in green because that is the dangerous zone. If you're gonna have a fracture through the growth plate, it happens through the hypertrophic zone. And then you have the zone of provisional calcification, and then you have the ossification zone, where now you have calcium and other stuff laid down and it become normal bone. So if you took it in picture, this is a growth, a physial. So this is the cells that we're talking about. The resting zone, the cells are scattered. They are just undergoing metabolism, but they are not growing. Then in a zone of proliferation, they start growing rapidly in number. Zone of hypertrophic, you get cartilage, but the cells themselves are growing in size, not necessarily in number anymore. And then they start calcifying, and then they become normal bone, which is your metaphysial bone. So in the zone of hypertrophic, or that's where the fractures happen the most. Next. And then it's not the complete story of a growth plate. When you look at this picture, this is the epiphysis, and this is the growth plate or the physis, and this is the metaphysis. So the cells that are resting are more towards the epiphysis, and the cells that are calcifying are more towards the metaphysis. This is towards the shaft of the bone. Now, the cells that are resting, you can see, and then the cells that are growing are there. But there's also cells on the side, which we call it the perichondral ring. These are responsible for the girth or the lateral growth of the bone on the growth plate itself. We'll talk about this perichondral ring and perichondral artery, or this area. This is called the perichondral ring. We talk about it because it is important when you have to classify the growth plate fractures. So when you have fractures, the fractures happen through the zone of hypertrophy. So in terms of the angle itself, the angle is got a number of bones, but the important ones, you have your talus, and then you have your distal tibia, and then you have distal fibula. Your distal tibia, your tibia plafond, which is the transverse area there, and then on the medial to that, you have your medial malleolus. Then you have your lateral malleolus, and in between them, the distal tibia and the distal fibula, you have your syndesmosis, or your distal tibiofibular ligament. And then you have your talus bone, which is almost completely covered by cartilage, and it doesn't have any ligament incision on it. Let's go. Yeah, and then when you go to a child, you still have the same bone. That's your distal tibia, and that's your distal fibula. That's your lateral malleolus, and this is your medial malleolus, and that is the talus bone. But again, now we can see, because as a child, you can see a growth plate through the distal tibia, and you can see a growth plate through the distal fibula. And the two growth plates are not necessarily at the same level, with the distal fibula slightly lower than the distal tibia. And when you look at this, the bones have to be joined together by something. So that's where you have ligaments. We talk about them just now. So in terms of the physis of the tibia, when the child gets to, a boy gets to the age of 16, a girl gets to the age of 15, the physia or the growth plate closes. The closure of growth plate happens in stages. It starts in stages, and it is controlled, by estrogen. Both in males and females, it is the estrogen that controls. So in girls, they get a surge of estrogen earlier than boys. Hence, the estrogen slows the proliferation and hypertrophic, and causes hypertrophic changes in the chondrocyte. So it causes closure. So in girls, it's earlier. In boys, it's a bit later. But the closure of the growth plate itself happened first. It happens central part of it. Then it goes to the medial side, and then the last part is the medial side. It's important to remember this when you are actually thinking of this type of fractures, because it goes with how the fractures happens or take place. And if you look at this picture, the closure of the growth plate, it starts central, then it goes to the medial, then from medial it goes to the lateral. You can see this is lateral because your fibula is there. So it's central, medial, lateral. And then the bones, like I said, they have to be connected together by something, and that's where you have ligaments around the knee, which used to be our nightmare for many of us when we were still in medical school. Because medially you get the deltoid ligament, which is ligament with 4 limbs, and you have to remember all the 4 limbs. Then you have your syndesmosis, which is quite a word that was difficult to say, but it is a distal tibiofibular ligament. On the lateral side, you also have 4 or 5 ligaments, but the important one is your anterior talofibular ligament and also your lateral ligament. The anterior talofibular ligament is important because it's, okay, I have a picture of it. The anterior talofibular ligament, it goes from the fibula and it goes to the talus. And now with the fracture going from the fibula to the talus here, and this part is the last part to fuse in a child. So when a fracture happened, like I said earlier up there, the ligaments are stronger than bone. So if the ligament is going from here to there and this part of the bone is the weakest part, you end up with a fracture in this area. We'll talk about it as we go on. So this is the some graphs that are showing the ligaments on the ankle. So that's your tibia, that's your fibula. So this is a picture showing the lateral side. And on the lateral, you can see a ligament which goes from the anterior, which is this one, and is talofibula. So it goes from the anterior from the talus to the fibula, or fibula to talus. So that ligament is your anterior talofibular ligament. The other ones are important, but in terms of in children, that ligament is important because it causes avulsion of your lateral side of your distal tibia. On the lateral side, you got your deltoid ligament with its multiple limbs. And this is a picture from the anterior where you can see your anterior talofibular ligament again. And then you have anterior superior talofibular ligament, and you have an inferior talofibular ligament. There's still a posterior talofibular ligament. So the anterior, or the ATFL, is the most common or the most important in this case. So in terms of fractures of the distal tibia or fractures of the ankle in children, they are common. So 5% of all pediatric fractures are ankle fractures, and 5 to 20% of pediatric fractures are physeal fractures. So they now involve the growth plate. The fractures are common in males more than in females, and the reason that was cited for that is males mature, or they skeletally mature later by a year or two than girls, so they have a longer span of getting these fractures. And it also goes with the type of activity that boys are involved in. And then the peak incidence for these fractures is usually the age of 8 to 15 years. The causes for it, the commonest cause is usually sports, like all the combat sport, rugby, and any sport that involves running, soccer, and all the other sports. The second, though, is usually low energy falls, where the child is walking and they step in an uneven ground and then they twist the ankle. Usually the twist is either inversion or evasion. And then you also have motor vehicle accident and other accidents that cause this type of injuries. But commonest is sports. That was supposed to be classification. So we get the commonest classification that we use for physeal injuries, which in this case, the distal or the ankle fractures in children are usually physeal injuries, is your Salter-Harris classification, which is 1 to 5. I think we have all at one stage recited and crammed it and we know it. But it gets a little bit complicated. I talked about the perichondral ring, which is responsible for the lateral growth of a growth plate. And when you have a fracture of the perichondral ring, then now you have a type 6 fracture. And this was described by Mesa and Rang. And then when you have a fracture that only involves the epiphysis, usually it will be on the medial malleolus, if we have to call it that, but only on the tip of the medial malleolus. Now, Ogden described that as a type 6. So they added on the Salter Harris. So Salter Harris now goes up to 7, sorry. And then you have your Dias-Takhigian classification. In adult orthopedic ankle fractures, the common classification we use is your Weber classification, which most people know. But there's also the Loger-Hansen classification, which describes the mechanism, the fracture in relation to the mechanism of injury. So whether you have supinated or you have pronated. In children, Dias-Takhigian also come with a classification that describes the mechanism of injury in relation to the fracture, to show how the fracture can happen through the mechanism of injury. And then there's something called a triplane and also a Tilou fracture, which are still Salter Harris type, but they it's like multiple of them at the same time. I'm gonna go through those ones by one. So Salter Harris classification, again, this is a normal, let's say it's a distal tibia. You got your metaphysis, you got your growth plate, and then you got your epiphysis, and this is the joint. So if you have a fracture that goes straight through the growth plate without going up or down, without going to the epiphysis or without going to the metaphysis, whether it displaces or it does not displace the growth plate, that will be a type 1 Salter Harris classification. If you have a fracture that goes through the growth plate and then it goes up towards the metaphysis, that will be a Salter Harris type 2. And that part of metaphysis that is below the fracture is also important. It's like a pathognomic of a type 2. And this is the commonest Salter Harris fracture. If you have to take a guess on Salter Harris, say type 2. Then when you have a fracture that goes through the growth plate, but it goes down or it goes towards the joint, that will be a type 3. So it goes through the epiphysis. And then if you have a fracture that involves both the epiphysis, metaphysis, and it goes through the growth plate, then that becomes a type 4. Now, the fracture that is the most nonsense of them all is a type 5. That's usually a fall from height with a straight limb and the growth plate is crushed. This problem is it's easy to miss when you look at the growth. When on the x-ray on a patient, you see the growth plate is visible and it's not displaced, and you don't see a fracture on the metaphyseal or epiphyseal, and you're like, it's normal, which goes back to the rules of x-ray in orthopedics. You have to do 2 views, 2 times 2, but the important one in this is you have to compare the left and the right, or you have to compare with the contralateral limb. Because when you see a growth plate that looks like this, and then you go and compare with this, you can see this growth plate is actually smaller. So this is a crushed growth plate. And these have a high rate of growth arrest. So it's important not to miss a type 5 Salter Harris classification. So this is again a review. This is a type 1 Salter Harris. This is a type 2, where you can see the Austin-Lewis fragment there. That's what we call that one. And then this is a type 3 where it goes through the growth plate and down to the epiphysis. And then this is a all 3 metaphysis, growth plate, and epiphysis. And this is a compression. Now, here's an added one now. This fracture has taken out the perichondral ring. This is the part that is responsible for widening of the joint or of the growth plate. So this is the one that was added by Mesa and Rang, and it became a type 4. And then if you look at this fracture, the growth plate is intact. The fracture has gone into the epiphysis. The important thing about this fracture is it involves the growth. It involves the joint line. So this is an intra-articular epiphyseal fracture, and this was described by Ogden, and it was added as a type 7 of the Salter Harris. Then, in terms of, okay, after all said and done, in terms of ankle, you get a number of motions that are very difficult to determine. An ankle can pronate, which is like almost, you can say it's external rotation. But again, external rotation is also another motion of the ankle. So there's pronation and there's supination, which we can do both in ankle and in the upper limbs. And then there's invasion, which happen in the subtalar joint, and evasion, also happening in the subtalar joint. Invasion is when you're moving the leg in and just the foot in, and evasion is when you're moving the foot out without moving the toes. Then there's plantar and dorsiflexion, and there's medial and lateral rotation, where the axis is on the tibia. What is rotating is the foot. These motion are important. When you think of ankle injuries, they happen when you have some of this motion. When you have a supination, you're likely going to start fracturing on the lateral malleolus, and you can also go through. If you have a pronation, you're likely to start fracturing on the medial side. And that's where Dias and Takijan came up with the classification where it's related to the motion. So if you have a supination and inversion, first you're going to have a fracture that goes, or early, if you have early, you usually have a fracture only of your distal fibula growth plate. And next, it can go distal fibula and it can go through the lateral side. And if it's severe, it causes fracture on them, like a Salter Harris type 2, where it goes through and out. More severe, it will cause a Salter Harris type 4, type 3, sorry, and then a type 4 with flat one. If you have supination and external rotation, you're likely to get a fracture that involves more the tibia than the fibula. And this is very important. We're going to talk about it, something called a triplanar fracture, because it looks innocent, especially this. Yeah, it looks innocent, but if you look at it in 3 planes, you're going to find it's very difficult to explain fractures. I'll go to that just now. But Dias and Takijan, all they were doing was to explain the mechanism of injury and the type of fractures that you get, same as the Loger-Hansen classification in adults. So the fractures, again, reviewing, you have your Salter Harris, which is type 1, type 2, up to type 5, and then Mesa and Ring added a type 6, and then Ogden added a type 7. And then Dias and Takijan described the mechanism of injury. Then you have something called a triplane or a triplanar injury, which happen in adolescents who are approaching skeletal maturity. It's usually 5 to 15% of all fracture in pediatric patients. And this is caused by external rotation mechanism. It is a combination of a Salter Harris type 1, type 2, type 3, and type 4 all together. So you will not see it in one plane. If you do an AP X-ray, you are only going to see it as a type 3. If you do a lateral X-ray only, you're going to see it as type 2. So you have to do a AP and a lateral X-ray, and then you can see it's as a complete. So this is an X-ray. This is the top one, top left is a normal X-ray. You can see the lateral fibula and growth plate, and you can see the, oh no, so there's a fracture there. You can see a lateral fibula, and then you can see the growth plate there, and you can see a type 3 fracture there. So if you do one view on this, you end up saying, maybe we can treat this conservative. But when you do a lateral, now you see a type 2 fracture. So you have both a type 2 and a type 3 fracture. If you do a CT scan, then you see it all together as a type 1, 2, and 3 fracture. Type 2, 3, and 4. So that's a triplanar. Then you have something called a Tilou fracture, which was described by a guy from France. So 12% of all bones, it involves of all physical bones in children, of course. It is Salter Harris type 3 fracture, and it is intra-articular. That's the important part of it. It is caused by supination and external rotation. Now, remember that ligament was talking about, the ATFL ligament, anterior talofibular ligament, which start from the distal fibula and goes to the talus. And then the growth arrest of, or not the growth ossification of the distal fibula, the last part is the lateral side. So with that, you end up with something like this, where you have the ATFL ligament there, which is holding the tibia to the fibula, or the fibula to the tibia together. And then you have your area, which is the last part to ossify, the lateral part of your distal fibula. So when you have an external rotation and supination motion, you end up with that part avulsed. And if you look at Salter, this will be a Salter Harris type 3. And this is common in these children, in children. And you shouldn't miss this, because it's actually part of an avulsion fracture. And if you go back to orthopedics basics, one of the indications for ORIF, or fixing a fracture open, is avulsion fractures. So if you do an X-ray, usually it will look like that. So the fibula is somewhere there, and you can see a Salter Harris type 3 fracture. Of course, one view is not obvious. It's one view is no view in orthopedics. So when you do a lateral X-ray, you do not see a Salter Harris type 2 here. You only still see a Salter Harris type 3. So in both view. If it was a triplanar, you're gonna see this, and then you're gonna see that one going up now. So this both confirm this is a tilo fracture. Okay, so now you have patient who comes to your rooms or to your practice, and you suspect they have a Salter Harris fracture of the distal tibia, or you suspect they have an ankle fracture, or one of those that we were talking about. What do you do? The important part, the first part that you do, is you're going to see the patient as they walk in, and you're going to take history. The history, you have to think back to what can cause. Is it low energy or is it high energy? So you ask the mechanism of injury. If they give you that you were in a car accident, it's difficult to know. It'll be difficult for you to put it into the diasyntachygen. But if they say, I was walking and my leg twisted, with a little bit probing, you can know whether it's inverted or is everted, or is internal or external rotated, which gives you a clue on where you're going to find the fracture. So the mechanism of injury is important. In children, mostly will come with reporting an inability to bear weight. It is important to check the duration on when did the fracture happen, because growth plate, remember, it's a fracture happening in the hypertrophic zone of the growth plate, where healing is very quick. In 5 days, the thing is uniting. So you need to know the duration. When did the injury happen? And then when you examine them, you get first, once you've done the ATLS and you've done ABC and Jekyll and all those other things, then you go and examine the hip, the knee, and the ankle. Because in children who have malalignment of their hip, knee, and ankle, they'll usually walk with an abnormal gait, which predisposes them to stepping abnormally. So they either invert or invert, or the external rotate or not. And that will give you a clue on why they have that injury. And if you just treat that and leave them, they probably come back with another one. So they need that treated, and they also need probably somebody to realign their limb if need be. So examination findings, when you find them, usually they will be swollen. The swelling can be very severe with skin tenting, especially if it's like displaced fracture with hematorosis and severe swelling. And they can have a deformity where the foot can come either inverted or everted, and you can see bone protuberance. And they will usually have decreased range of motion, and again, they will probably not be able to bear weight. You must also check the pulses and have a high index suspicion of compartment syndrome because of the increased bleeding. Once you have seen this patient, the next thing you're going to do is to do investigation. You can diagnose most of these fractures or injuries using just plain x-rays. The x-ray that you need to do is an AP, a lateral, and a mortise. If you worried and you want to describe the fracture better, especially when you suspect you have a triplanar, do a CT scan, because the CT scan is going to give you 360-degree round, so you are less likely to miss a triplanar with a CT scan. MRI in ankle pediatric fracture is got minimal role. Usually you don't do it because majority of the time, like I said, the ligaments are far stronger than the bone. So you hardly get ligaments injury, you get fractures. In adults, it's the opposite. The ligaments are weaker than bone. So in adults who supinate or pronate their leg, they usually get rupture. And it's that very same ligament, the ATLF ligament. In adult, the ATFL rupture, and an MRI become more imperative than a CT scan. So talking of X-ray, that would be your AP. Oh yeah, that would be your AP X-ray of an ankle. You can see the distal tibia, you can see the distal fibula, you can see the growth plate, and you can see the growth plate, and you can see the ankle itself. And then this is the mortise. But again, now when you look at this view, that part, that little part corner of the, how do you get there? Okay, that corner of the distal tibia, you can't really see it nicely. Yeah, trying to see that corner of the distal tibia, you can't see nicely. So you need to just slightly internally rotate or invert the foot, and then you now see the whole distal tibia or the whole epiphysis. And if you have had a T-loop fracture, which will happen here, you are more likely to see it with a mortise view than with a just an AP view. And when you're doing reduction, if you're gonna do close reduction on this patient, you need to have X-rays there, and the X-ray that you need to do, the important one, is again your mortise view. This is a lateral view of an ankle in a child. And this is a CT scan that was done that is showing a salt iris type 3 that you can see there. And you can see the fracture extending intraarticularis on the distal tibia. Okay, next. So now you have a patient with a distal tibia or an ankle fracture and is a child. How do you manage this patient? The important thing again, high index of suspicion. A child that cannot bear weight, a child that has a swollen ankle with reduced motion, a child that something is just off, it doesn't behave like a normal ankle. Rather send them for X-ray or rather send them to somebody with a little bit more expertise to make the diagnosis. Because the problem with missing this is you render the child with a growth arrest or with a deformed leg or a leg that would grow abnormally. So management of this, the goals of it is anatomical reduction. Remember, it's an intraarticular fracture, or some of them are intraarticular fracture, and with intraarticular fracture, you need anatomical reduction of less than 2 millimeters. So you need physial or you need growth plate alignment or realignment, and you need to avoid growth arrest or growth plate arrest, and you need to prevent degenerative arthritis. So those are the goals of your treatment. In patients who come with undisplaced fractures, when you've done all views and you just see an undisplaced fracture, usually it will be an undisplaced physial fracture of your distal tibia, distal fibula of less than 2 millimeters. Those patients, you can put them on a moon boot and you walk on a moon boot for 4 weeks, it usually heals well. Patients who come with fractures that are displaced, that are intra-articular, you want to treat them conservative, you're gonna do close reduction and a POP. And you have to do this best case scenario in theater with a CM. And you're not going to manipulate these patients many times, because as you're manipulating your hypertrophic zone of your growth plate. So you're manipulating the growth plate itself. The more you manipulate, the more you damage the growth plate, and you end up causing growth. So you only attempt twice. And once you have done the reduction, you do a Motors view to confirm your reduction. And if the reduction is good and is less than 2 millimeter fracture displacement, then you can put a POP. And the POP you put below knee POP, and you keep the cast for 6 weeks. Patients where you take to theater, you did your 2 attempts and you fail to reduce it. Or patients who come with severe fractures, those patients you take to theater and you have 2 choices: close reduction and percutaneous pinning, or close reduction and ORF. So percutaneous pinning is you reduce them and you put a wire. You can also still use the wire to reduce, where you joystick with the wire. If there is interposition of soft tissues into the growth plate or into the joint, you have to open those patients, reduce that, and then you have to pin them differently. If there's a varus deformity of more than 10 degrees or a valgus of more than 10 degrees, also those patients will need ORF. So you'll need to open. And this is examples of patients who were treated. You got a patient who has a distal assault iris type 1, very severely displaced, also with a distal fibular fracture. So after reduction, a POP, KYs percutaneously were inserted. Those are holding the growth plate this side, and you can see they are crossing. So you're holding the growth plate in 2 places. So that's close reduction and percutaneous pinning. And after the removal of the KYs, you see the fracture is held. Next, you have patients with, again, it's assault iris, the type 3. Yeah, this could probably even qualify for a type 4, but important part is it's an intra-articular fracture that you can see. So these patients, you are likely to open and get compression of the fracture itself. And in this case, a cannulated compression screw was inserted, and you can see the reduction, it was good. Then patient below the, and then also the distal fibular growth plate was fixed with a wire, as you can see. So this is a patient who was taken for ORF. Yes, other cases, you can see this patient has a fracture there, and if you remember on the classification, this one will be the one that was described by Ogden, which is an intra-articular fracture only on the physis. So open reduction was done and the KY was done, but when you do a lateral, you can also see there was a fracture or a assault iris type 2, which was fixed with a screw. So these are just other method of fixation that you can see. Okay, a little bit complicated a slide, but this is my last slide. So when you have a child presenting to casualty or to your rooms with ankle fracture or ankle injury, you have to do a detailed clinical examination. And when you've done that, your Ottawa rules will probably say you have to do x-rays of this patient. And when you do x-ray, do an AP, a lateral, and a mortise. Mortise is kind of important in this case. And then if your x-ray, you see a fracture, you're going to classify it. Assault iris type 1, type 2, Undisplaced, you're gonna put a cast for 4 weeks or a back slap. If it's displaced, you do close reduction and a cast, or you can do close reduction and percutaneous spin. If you have a salt iris type 3 and type 4, so those involve more. So you probably undisplaced, you can do percutaneous pinning. Displaced, you probably end up opening. That's because you probably likely attempt close reduction and it will not work, and then you end up opening and put a screw. A transitional fracture. So this is where you have a fracture and you're still worried about, well, is a salt iris 1, 2, and 3, or is it a 2, 3, and 4? Something's not off. Then you end up sending them for a CT scan. If the articular displacement is less than 2 centimeters, you're still gonna either percutaneous pin or put them on POP. If the displacement is more than 2 millimeters, that's most likely you will end up with open reduction. That's, you still try close, but most likely you end up with open reduction. Where you have normal X-ray after doing, you have a patient with the patient has got a fracture, but you do X-ray and it's normal. If the limb is not swollen, you have little suspicion that the fracture is there, you treat as an ankle spray. But if you still have high index of suspicion and suspect this thing still doesn't give you joy, the swelling is too much, the pain is too much, unable to bear weight, that's the patient that you will send for CT scan. And then if it's displaced, close reduction and percutaneous pinning. If it's not displaced, you put a POP. Okay, that's pretty much my story on how we manage pediatric ankle fractures. And the reason, again, for describing this is they are very much commonly missed. And the problem with it is the evidence are usually there that you miss the fracture. When this thing goes to the lawyers, to court, to medical legal, they retrieve the first X-ray and they're like, oh, you missed an ankle growth plate fracture. And it will be very hard to defend yourself because now you have the evidence that you missed it, and then you have the patient who's as a growth arrest. Now they have a shorter limb, so missing it is not a good thing. If you're worried, rather send it to a hospital, send it to somebody who's going to treat it. It's better somebody else goes and look and do a CT scan and then say there's nothing. Thank you, Doc.
Thank you very much, Doc. I actually liked ending on that. Rather treat with a high suspicion and refer, rather safe than sorry. So let's start with a question that we've got. It says, how about a skeletal health optimization to prevent future fractures?
What?
How about skeletal health optimization to prevent future fractures? So I assume we're looking at how do we optimize skeletal health in children.
Well,
yes.
Look, this very little that you can do to prevent these fractures. It is very easy to prevent them, actually. You just stop the growth of the growth plate. Once it's not growing, then you can't. But now you have rendered the child not growing. So you can't prevent them. And there's not much you can give in terms of supplements or anything that makes growth plate either grow faster or slower. You don't want to do anything to a growth plate. You don't want to mess up with growth plate. Even things like when you're giving calcium and other supplement, you are not giving them to have any control of the growth plate. You rather control after calcification how much calcium is stored or not stored. But you don't want to prevent the chance of, you don't want to, you cannot.
All right. Next question. Thank you for that. How soon should one repeat x-rays in order to rectify the errors or missed fracture?
Well, which is why even when you're doing a close reduction and POP, you're going to do it with a CM. You have to do this with an X-ray. So you have to correct it right there. When you leave theater, you should say, I have reduced this to less than 2 millimeters and put a POP or put something that stabilizes it, whether it's a screw, a wire, or a POP. But you need to leave theater happy that you've done the correct or the absolute correct thing. You only have 5 days to go for this fracture to start uniting. You have a very short period of time. If you're going to repeat the X-ray in 2 weeks, the thing is already united. So the best time is the first time. Later, you're not going to gain much.
All right. Next question we have from Dr. Dlamini. Is it possible to have a normal X-ray soon after injury? If so, how soon should we repeat the X-ray? So I guess this is from a GP's point of view. And also this happened to me, personal experience as an adult.
Well, in this case, if you're the patient and they come and you do an X-ray, you are worried that they might still, something is not correct. That's the patient in the flow diagram that I showed. That's a patient that you're going to CT scan them. Until you are happy, oh, you have done a CT scan, says really there's no fracture. Do not be happy. If there's still something that worries you, CT scan them.
So from my days when we were in GP practice and we couldn't always get a hold of specialists like you, we would moon boot the patient or immobilize them, especially when we had a normal X-ray. And I know that tends to be quite still prevalent, a practice amongst GPs, especially when they're further out from specialists, is that you'll immobilize the patients and then send them home with pain management. And I think after you've done that, and then that flows then into my question that Andy has, is that for patients who are treated conservatively, when do we then follow them up?
Once whatever you've done, or if you've done close reduction, or you've just given them a POP, your follow-up usually is 2 weeks, the first 2 weeks. And what you're following up to do is to check if your POP is still intact. If it's not, you're going to reapply that POP to make it tight or to make it snugly nice. But the follow-up is not mostly to say, oh, I have missed it. This is where you shouldn't necessarily be missing this one. So your follow-up is usually in 2 weeks, but to check your POP, because usually with swelling and first POP, it does get loose at times. So you need to repeat it in 2 weeks just to check if the POP is swelling. X-ray follow-up, if your POP is loose when you do your 2 week, then do an X-ray.
So we've got another question. Well, the questions are coming for you, Doc. We've got another question that says, what will be your approach in a gunshot communicated ankle fracture?
The question coming from an anesthetist. Yeah. Look, comminuted gunshot ankle fracture. It's the treatment it's a whole lot different from treatment of this. Like now you have added, he has added an extra part, which is an open wound. So now you have a bigger worry called sepsis. And now you have a worry called comminution. So you have multiple bones that are fractured. The good part about gunshot and comminution is comminution is your friend. When bone is comminuted, it actually have a lot of surface area, so there's higher chance of union. It's displaced fractures that don't unite mostly. And then in terms of gunshot also, as comminuted they are, gunshot are technically sterile because the high velocity, high heat that they produce. So you more gonna treat the open fracture part of it. So you're gonna end up with an X-fix or something else for the comminution, because you can't treat comminution with, you can, but mostly comminution you're gonna treat with an X-fix. So it goes kind of a different direction. If it's in a child with growth plate still open and is comminuted, you're most likely going to do open reduction and try to put the growth plate as best as you can. Probably end up with multiple wires rather than multiple blades and stuff. Blades and nails are not necessarily indicated in this case.
All right. Next question, looks like your last question. Does musculoskeletal ultrasound not play a better role than CT scan, especially considering the cost and availability in most settings? That's from Dr. Moyo.
Musculoskeletal ultrasound. No, it doesn't. But you have a patient with a bone. This is more bone. Like I said, back to slide number 3. You got ligaments that are far stronger than bone. These patients get growth plate fractures, not ligaments. When you're doing an ultrasound of a bone, you will not get a better ultrasound than a CT scan. A CT scan will always be superior to an ultrasound in terms of bone and seeing fractures. So if you really want to see the ligaments, yes, you can do an ultrasound, but it's a little bit on the lower side. So an ultrasound, even if it's musculoskeletal ultrasound, it will not help you. And in terms of prices and thingy, that's a very catchy thing. Usually, if you can afford doing an ultrasound on a patient, that's probably a good 3, 4. You might as well do an X-ray. Do an AP lateral and a Mortis X-ray. They will actually give you far a good answer than an ultrasound, and the price will probably be less. So rather do X-rays or views or do CT scan. Ultrasound is of little value. MRI is of little value.
All right. Oh, Doc, they're not letting you go. Next.
No, I don't want to go either.
Not sure if Doc can assist with this. Looks like you've got a case. How to treat an 11-year-old boy presenting with limb length discrepancy. Parents do not recall any trauma. But do say the child never put weight on the affected leg. Currently still waiting for X-rays.
Well, I think that patient shouldn't be waiting for X-ray. That patient should be waiting for examination first, because limb length discrepancy is a big topic. The limb is got 2 imported bones, or it got 3 imported joints. You have your hip joint, your knee joint, and your ankle joint. Majority of the lower limb growth happen in the knee joint. If you have LLD, it's most likely either your distal femur, your proximal tibia, that growth plate that has arrested, or it's on the hip where you either have a SUFE or you have DDH or you have something happening on the proximal femur around your hip joint. Yes, ankle can give you LLD, but it's not as bad as the ones on the knee and hip. So the first part of this patient, 11-year-old, it's good examination where somebody can determine where the fracture is. And if this patient is waiting for X-ray, let the X-ray be a lower limb scanogram, where you see the hip, the knee, the ankle in one view. That way, even the radiographer can measure the length for you. Then they tell you, when you talk of LD, you have something called apparent and a definite limb length discrepancy. So now you check if it's a true, an apparent or a true. So you can check where the limb length is coming from. Until you get to answer that one, then you can't really say what can be done, depending on where it is. But there are options in terms of limb length discrepancy on what can be done. One, you can easily lengthen the limb if it's possible. And lengthening the limb means you cut the bone and you do destruction, osteosynthesis, where slowly with an X-Rix you increase. That's usually for a tibia. Two, you can stop the other side from growing, where you close the epiphysis on the opposite limb. So the one limb grows lower than the other and they catch up. Three, depending on where it is, if it's something like a SUFE, you're gonna go treat whatever is on the hip. If it's DDH, you probably let the patient reach skeletal maturity and then you do a hip replacement or something. So the options are there and there are many. But a good examination, I think, don't know if Mapasiga is an orthopod, but if not, refer to an orthopod.
All right. Just for me to answer Samson, just look out. So we vary our topics and we vary our speakers, but we will have future orthopedic presentations. So always look out for the invites. From Dr. Magagula, we've got, in terms of antibiotic prophylaxis prior to dental treatment, what's the protocol for patients who have had intermedullary rods placed or joint replacements?
What?
So for patients who are going for dental treatment, and if we need to give them antibiotic prophylaxis, those who have had rods placed or joint replacements, what type of antibiotic prophylaxis would you give them for dental treatment for those types of patients?
Okay. It's to answer this one, there has to be two scenarios to this. Let's say it's a hip replacement or a knee. It was done and the patient is healed. There's nothing. So that patient already, the joint is closed, it now has a capsule and is working properly. The prophylaxis that you give is related to whatever the normal dentistry prophylaxis will be given. So it doesn't change anything because the patient has had a joint replacement. If it's healed, it's fine. You continue with the normal protocol. If it's a patient who has done a replacement, either it has not healed yet, it's too early, or that patient has got periprosthetic joint infection. It's going to be a catchy one. It's going to be a difficult one because with periprosthetic joint infection, those patients already have bugs and they've developed a biofilm and they got gram-negative and gram-positive all together. And most of the time they are already high on antibiotics. The best thing to do will be to do a blood culture, check their FBCU and their CRP and ESR and their clotting, their infection markers. And then you can continue with the antibiotics that they were taking. Because they are already on antibiotics and they are on higher spectrum antibiotics. So you're not really going to do much damage to them by that. But it's a catchy one. It's a tough one. I don't know what dentistry do. Down.
All right. Doc, thank you so very much for your talk today. Just to let our audience know, if you have any other questions, please send them through to us at the usual email address and we'll pass them on to Doc, who will then answer them and we can send them back out to all our participants today. I want to say once again, thank you. Thank you for your time and for your talk, and we will see you at our next talk. And
Definitely.
definitely, Doc. Just letting the audience know, Doc will be giving future orthopedic talks, especially for next year. So I want to thank everyone for joining us tonight, and I wish everyone a good evening. Goodbye.